Hilary O'Connell is the Wellness and Reablement Lead for Independent Living Assessments WA. Hilary, welcome along. She's going to be introducing the why of reablement for us at the start of the forum, and she's got an extensive background in this issue. She spent 40 years as a clinician, manager and leader across disability, aged and the community care sectors. Over the past 20 years, one of her primary focuses has been on supporting the development of prevention and reablement service models. And that included a period of time where she set up Australia's first community care reablement service. She's involved internationally via the Australian arm of the International Reable Network, and has been a driving force behind the creation of KeepAble and its focus on reablement and strengthening the knowledge base of community care service providers in this area. So, Hilary, without further ado, I will hand over to you to kick off.
Thank you, Paul. I'll just get my presentation up a moment. There we are. Well, thank you everybody for attending today. I do hope you're going to get a lot out of this presentation. And as Paul said, yes, I've been working for over 14 years now, but been involved with reablement and preventative models for some time. So I'm going to give a bit of an overview of what I call the why of reablement in some ways, and then how that works in with healthy aging and how we can work with people to give them the best life possible and enable them to live a full life. First of all, I would like to acknowledge the traditional custodians of the lands, skies and waters throughout Australia and pay our respects to elders past and present. And we specifically acknowledge the Whadjuk people of the Noongar Nation, the traditional custodians of the lands on which our head office is located in Burraloo, Noongar, Budja, Perth, Western Australia. So first of all, I thought we'd sort of see it from what us older Australians are actually telling us. They're telling us, we did a snapshot survey not that long ago. They're telling us that they want to stay at home and live independently for as long as possible. And then we've got to think, well, what does staying at home and living independently look like? And what do we not only need to be able to do from a physical, mental and social perspective to function at an optimal level, but what also do we want to be able to do? So the need side of things would be your normal daily living activities. But most of us want more than that when we age. We also want to be able to still walk the dog, play with our grandchildren, go out to the shops, do different hobbies and different groups and things like that. And if we do need services, then how should those services operate to help us to stay at home and to live as independently as possible? And I think if there are certain skills that we need to be able to live independently, then how do we keep people up the curve for as long as possible? And this is a sort of a study that was done back in 2017-18. And you can sort of see the curve and the light blue line, and then the line on the right hand side. So starting at cutting toenails, shopping, using steps and things like that. This study was done using international data, and from the cutting toenails down to the eating independently, what it was discovered that these are the essential activities of daily living. And within 10 years, people dropped from cutting toenails down to not being able to eat independently unless something was done to actually help them not go there, to actually intervene through things like reablement services. So what we want to do is keep people as far as possible on the blue curve for their optimal way of living. And then we've got to look at how can we manage that as providers? If we need support, how do we work with people to actively prevent loss of function? Not just to help improve their independence, but actually to actively reduce the impact of age-related decline. And then what role does the individual themselves play in supporting how they age? Some facts, you probably all know this already, but by 2056, Australia's population is projected to be about 35.5 million, and around 1/4 of these will be 65 years or older. And there are obviously proportionately fewer younger Australians as well. So there's fewer adults in the working age, fewer adults in the workforce, and there's likely to be greater demand on services, which is likely to place further restrictions on the availability of services. Because people are living longer and we're living much older ages, more chronic conditions are more likely. And so we really do need to invest in prevention now and provide care within a framework that actively supports people, to firstly regain where possible, and then at the very least to retain their independence. And when I talk about independence, I mean physical, social, and mental, so that we have a good quality of life in later years. We know that this is part of the government's direction and has been over the last sort of number of years. The Royal Commission certainly made that quite clear. The Support at Home programme, Single Assessment Service, the 5-year age positive strategy, the government's 5-year age positive strategy, and the quality standards all have prevention, healthy aging, optimising independence, health and wellbeing, and reablement as key requirements for a future system. And not only inside the system, but actually outside the system. So not preventing people from entering the system, but helping them enter it later. Prevention, we know it's never too late or too early. And when I talk about healthy aging, it's not the absence of disease, but it is a process of helping, developing and maintaining physical, social, cognitive, and mental health that enables well-being in older age. And it's about maintaining people's functional ability to meet their basic needs as well and make decisions and contribute to society. There's an awful lot of evidence around now that says only around anything up to 25% of how we age is actually down to our genetics. So age-related decline is only around 25% genetics, and the rest, or a large 75%, taking into account socioeconomic factors, is lifestyle. We know that 40% of dementia risk is modifiable. And I think it's so important that we start thinking about how we have a doing with approach and not a doing for, and start thinking as movement and activity and engaging with people and engaging them in the support that we deliver as medicine, that movement is medicine. We do know from a lot of the research that's out there that functional decline and the need for care are not inevitable consequences of aging, and that people need care when they're unable to perform some activities of daily living in their environment. But that decline when they need care can be minimized or even reversed. And there's a lot of evidence to say that if we help people too early, there's a premature loss of skills, which leads to a premature disability. And the Royal Commission were quite clear in some of their findings that passive care systems can affect the delivery of aged care. Attitudes and assumptions about older people can affect the delivery of aged care. And there's a lack of attention currently on prevention and reablement. And that, as a rule, as aged care services, we're not geared towards people's enablement, and we do not actively maximise improvement or maintenance of people's capacity and health. And as I said before, that age-related decline can be minimised or even reversed. Older people saying that their biggest concern, this is over 85% of the people we surveyed, said their biggest concern as they get older is losing independence, deteriorating health, and loss of social connections. There's even been studies that have said that older people fear losing independence more than they do death. 78% are increasingly finding it more difficult to perform simple everyday tasks. And over 90% said that we needed to be empowered to take steps to slow the impact. There's also a lot of evidence currently that people at middle age, middle adulthood, between the age of 45 to 64, are also starting to experience difficulties in performing simple everyday tasks. So we need to be taking preventive action, as I said, inside the system, but outside of the system as well. And this is a quote from the British Medical Journal back in 2019. I'll leave you to read it, but I think it's quite significant. So people who fear reduced independence, the solution is not to hope for a quick exit, but to do enough activity every day and with every diagnosis. Very busy slide. I'm not going to go into all of it. Again, there's more evidence coming out from the British Medical Journal and other medical journals that the need for care is determined more by an insidious loss of fitness than directly by disease processes. There was a really good article done that said exercise and physical activity may reverse the decline and keep a person above the threshold for needing increased care. And any physical activity for at least 10 minutes that gets someone slightly out of breath, such as housework, gardening, and shopping, contributes to this. So we need to be very careful when we're both assessing for services, but also providing services. Are we actually enable this person to stay as independent as possible and as fit as possible? And I mean by that, I mean stamina and strength and stability, so that they actually don't need more care as they get older. There was a recent study done in Australia that an unhealthy lifestyle is associated with an increased risk of admission to a nursing home in adults 60 plus, unless we do something about it. And reablement, as we know, is an evidence-based approach. So what we're saying is that to support people to live well into their later years, we need to be working in a way that's preventative and enabling them not to require increased services over time, so that they have a really good quality of life in their later years. So our approach to service delivery really does matter. We know that traditional service delivery approaches can de-skill people inadvertently by doing for and not doing with. There's a lot of evidence to say the more we do for someone, the less that person does and the less able they feel. They lose fitness and confidence and skills, and then the less they want to do, and so forth. And it's our responsibility as providers to understand the impact of our intentions, our interactions, and our approach. And as I said before, we need to support people to retain the skills. And there's more on this later around the skill retention and how you can build that into service delivery by one of my colleagues, Kirsten. My opinion, and it's certainly the way the government is heading, is wellness and reablement should be staples of aged care and not an afterthought. And we really have the knowledge and opportunity to make a real difference to people's lives, and every opportunity really does matter. And why it matters? It's because older people desire it. They want to stay living in their own home, in their own community, and having a good quality of life as they get older. It supports the findings of the Royal Commission. It supports human rights, and I know Joanna's going to talk about this in a minute. It's consistent with the science around healthy aging and minimizing age-related decline. And it can reduce the risk of someone needing longer-term care. Again, another article that was done in the Journal of Epidemiology and Community Health. There's a lot of talk about people wanting to age in their own home and not require residential care. People aged 60 plus, and I said this before, with unhealthy lifestyles are at double the risk of residential care admission. I think that's quite significant. So to sort of finish, some takeaway thoughts on this. 25% of how we age is genetics, and we can shape and control a large proportion of how we age. Older Australians fear loss of independence more than death. They want to live longer years if they're good years, and they do wish to be empowered to slow down the impact of getting older. Our assumptions and attitudes make a huge difference. Age-related decline can be minimized or even reversed. And done well, wellness reablement can actively prevent age-related decline and enhance an individual's capacity to live really well in later life. We do know from other research that's been done that staff providing reablement report higher levels of job satisfaction and retention. We know that wellness and reablement supports compliance with the new aged care quality standards. And I feel like it's a win-win situation for clients, service providers, community, and government. I think it's a moral imperative that we embed wellness and reablement and that we honour the rights of people we support to have the best quality of life possible. And I think also, if we're to look back to this, is lastly, if you were needing services, what approach would you prefer if you were the person needing services? If you were having difficulty showering yourself, difficulty during the shopping, would you like to be empowered to be able to do that again for yourself? I think most of us would. And that's it. Thank you very much.
Well, thanks very much, Hilary. We've just got a couple of minutes available, so we might take a couple of questions. I see from the chat two things. There's lots of people interested in getting a copy of your presentation. So I take it we can facilitate
Absolutely.
that. Yeah.
Absolutely, yes.
Great. And the other thing is some people have been saying they're denied access to the Q&A function. Just until we work that out, could I ask if you've got any questions, just to place them in the chat and we'll be able to see them there if you can't get access to Q&A. You were describing, Hilary, all the benefits, and they are very obvious and very significant. But why do you think there's a resistance, sometimes on behalf of older people themselves, but also on behalf of the service system more broadly, to actually implement reablement approaches to service delivery?
Look, I think there's probably a mixture of reasons. I certainly think that older people themselves and family members, uh, they haven't got the information about age-related decline, so they're not necessarily understanding what the trajectory is, and there's an opportunity to reverse that. So I think ageism, both from our own perspectives and from a sort of the people that we actually work with, our clients, they're ageist in themselves, saying, well, I'm old, what would you expect at my age? I can't do this. Whereas, and I understand that when you're feeling tired and you might be in a bit of pain and that's, you're not feeling very confident. But we do know that from the actual science that that can be turned around. So that's sort of starting point. So I think a lot of that's around education, knowledge, and building awareness. I think that's the same in the sector about building awareness. I do also think that it's from a reablement perspective, if we're delivering short-term services, obviously that's partly around education and information, raising awareness around how we work with people. But I think it's also within the sector, it's quite hard to deliver short-term services when you've got a lot of work to do, and if to move in people in and out of the system, to have someone just for 4 weeks as opposed to have someone for 6 months, for 2 years, it's more time consuming for a start. So it's much easier to see someone and for them to stay with you as a provider for life. But from my perspective, there needs to be more of people coming in and out of the system, or being optimized with a reablement approach up front, at the front end of the system. Then that the care is determined from there. So, but there may be a percentage of people who move out of the system for that, but then have to be able to come back in again quite easily. So I've got sort of differing views, but I think it needs to be more of that sort of focus.
Yeah. And Hilary Amaldoni's asked, could you comment on the access to and practice of cognitive rehab and reablement for people living with dementia?
I'm not an expert on that, but I absolutely know from a lot of the work that's done that cognitive rehab, cognitive reablement, and reablement from a perspective of someone with dementia is as important as someone without dementia. It absolutely applies. Some work that I did originally with Silver Chain many years ago, we actually had a dementia-specific reablement program. It was exactly the same philosophy approach, different interventions over a longer period of time. So there's no question about whether for me, there's nobody who is not appropriate for a period of reablement.
Yeah. Okay. And Chris Atmore's asked, the Royal Commission, as you mentioned, had focused on the importance of taking a reablement approach, and also stressed the importance of access to allied health professionals to assist with that. Particularly in residential care, it appears that we're going backwards to some extent on the provision of allied health services, and that's to do with the care minutes targets and so forth. Could you comment on how we might be able to turn that around, because people in residential care can benefit from a reablement approach as much as people living at home?
Yeah. I, but I've heard different stories from different providers of how they've actually managed to retain some allied health sort of, not hours necessarily, but they've looked at doing things differently and have sort of managed to have still some of that allied health input. I understand what you're saying, because I think there's also been a huge shift of allied health not being in residential care. Look, it comes down to the dollars in the end in that respect, and how a provider themselves might work. But I do think we can look at a lot of training for allied health assistants. We can sort of train residential care assistants. We can look at doing that. So there's no reason why the approach as regards still everybody needs to be supported to do a little bit more for themselves. That same approach takes place. You can look at the Montessori approach within residential care. Is anything I'm doing for this person taking away from their independence? I mean, I'm an allied health professional myself. I hate to see what's happening within residential care, but I do think we can look at, there's potential to look at other ways. I'm not quite sure what those are at the moment.
Yeah, I agree. And of course, we saw the fantastic effect on older people of their engagement intergenerationally with the Older People's Home for 4-year-olds on the ABC. And that, I think, showed that absolutely people are capable if you give them the right structure. And it doesn't always have to be a formal structured reablement intervention.
No.
It
It
can
can just fit the atmosphere and the environment and people coming in and out. That can change. People spontaneously respond to it. So whilst I'm absolutely in support of allied health, I think there are other ways of structuring things so people can still look at how becoming more independent or more engaged and have a higher quality of high well-being. I think there are other ways of looking at it if that's the way it goes.
And as you said, 10 minutes of physical activity per day can make all the difference to people's ability to retain functional capacity.
Absolutely.
Thank you very much, Hilary.
Pleasure.
You've got us off to a great start today, and we'll look forward to you being able to drop in and out during the rest of the day.
Thank you.